Thanks very much, Lindy, and it's a great pleasure to be back at Australia's premier health law research centre. And I can thoroughly recommend this conference, not because I've got anything special to contribute, but I think the other speakers are fantastic. And also Michael Selffulfilling is probably the world's expert in infectious diseases and ethics, and is on the WHO standing panel for this. So I'm a little bit PowerPoint challenged here because we've got two different computers. So this is not really about neonatal intensive care. That's just an example. And I really want to talk about two concepts. One is futility and one is rationing. Before I do that, I just want to quickly ask you your intuitions about this familiar case from philosophy. This is how philosophers spend a lot of their time, earning huge amounts of money. So you're in charge of this rescue service, and you're on this island, and you've heard that there's been 2 boating accidents, and to the north of the island is a raft with 1 individual on it, and to the south of the island is another lifeboat with 5 individuals on it. And you hear on the radio there's one of these big storms coming, cyclone, and you're pretty sure that if you don't get there in time, they're going to die in the cyclone. And you've only got time to go north or south. So north, you'll rescue the 1, south, you'll rescue the 5. So let's put our hands up. Who's going to go north? Who's going to go south? And who's going to toss a coin? 1. Well, that's actually pretty, I'm going to come to that. In fact, about 99% of people say they'll rescue the 5. About 1% of people say they'll rescue or they'll toss a coin. Famous philosopher John Turk said, if we're committed to equality, we should toss a coin, because the loss for each of those individuals is exactly the same their whole life. And if we're to respect them all equally, we should toss a coin. At the heart of rationing is the dilemma that we have limited resources. And rationing is about how to spend those resources when we can't save everyone. And in fact, I think this is at the heart of many of the judgments of futility, or the decisions that medical treatments will no longer be given to people. So just to give you a snapshot of the relationship of this talk to medicine in general, we now have tons of medical treatments, intensive care, 3rd, 4th generation antibiotics, 3rd generation chemotherapeutic agents, huge volumes of things that could benefit people. And there are 3 reasons not to provide them to people. So this is the sort of take-home message. One is the person doesn't want them. They're competent, they know the downsides, and they're acting freely. So the classic case of that, Jehovah's Witness refuses a life-saving blood transfusion, dies. But you can refuse anything. That's quite uncontroversial actually in ethical or legal terms. The second one is that it's futile, that it's not in the interests of the person to receive that medical treatment. So you'll be familiar with cases of people dying of cancer and some form of medicine being available and it being said to be futile, not in their interests. And I'm going to come to that because this is probably the most commonly invoked reason for not providing treatments that might have an effect for the person. And the third one is we just don't have enough money for them. They could have an effect, they're in the person's interests, but we just can't afford to give that to everyone. And that actually I think is the best justification for not providing treatment, not the second one. Now, just to give you an example of this sort of dilemma in real life, just to sort of take you away from the lifeboat case and give you a real this comes from the first paper. About 15 years ago, I was asked by Richard Smith, the editor of the British Medical Journal, did I tell you this story last time I was here? I don't think so, because we didn't have this talk. to write an editorial about this report called the Brompton report. And a number of families of children and adults with Down syndrome brought a case of discrimination against the National Health Service. And they said that their children were not receiving equal treatment because they weren't receiving cardiac surgery when people without Down syndrome would have received cardiac surgery. Now you may be familiar with the fact that Down syndrome is not just associated with intellectual disability, it's also commonly associated with various heart abnormalities such as hole in the heart, transposition of the great vessels and so on. And some of these are easily treatable with heart surgery. And what was happening at the Brompton Hospital were these children were not being operated on and being allowed to die of heart failure in their 30s. And the justification of the doctors involved was a paternalistic justification. They said it was in these people's interest to die of heart failure in their 30s rather than have their heart abnormalities corrected and get the advanced dementia that's associated with Down syndrome in their 40s, so they would be institutionalised in their 40s and 50s at a time when their parents would be dying. So they made this judgment that it was better, it was in the interests of the children and young adults with Down syndrome not to have heart surgery and to die earlier rather than later. That kind of paternalism isn't acceptable today. The views of the doctors about what's in the interests or whether it's in the interests of a person with Down syndrome to live. And I said this was clearly discrimination. It was treating people unequally without there being a relevant difference. So principle of equality, treat like cases alike unless there's a morally relevant difference. So that clearly was a case of discrimination. It was failure to treat people equally because there were enough resources, enough people, enough staff, enough money to give everyone operations. The grounds was not that they didn't have enough resources. The grounds that it was better for them to die earlier rather than later. It was a best interest judgment. But I said, yeah, that case is relatively straightforward. A much more difficult case is the case of heart transplantation. Now, hearts are another resource that they come in a limited supply. William Isdale and I have written a paper urging various policies to increase the supply of organs in Australia because there simply aren't enough organs for the people who need them. And in the case of children, there's only enough organs for 2 out of 3 children who need organs. So if you transplant a child with heart failure who has Down syndrome, you know that the opportunity cost of that is a child who doesn't have Down syndrome will die on the waiting list. Now, if you were to really take seriously egalitarianism or equality, everyone who needs a heart transplant should have an equal chance of having a heart transplant. So, show of hands, who thinks that children with Down syndrome should have an equal chance of receiving a heart transplant as a child without Down syndrome? Who says yes? And who says you should give priority to children who don't have Down syndrome? Show of hands. Okay. Well, in fact, the standard practice, or at least it was when I wrote that article, it may have changed, but I doubt it, was never to transplant children with Down syndrome. Maybe there are exceptions now, but they'll be few. The policy, the clinical policy, is to provide the organ to the child who will derive more benefit from it, either in length or quality of life. Okay? And if you think that's discrimination, you can go further back to more severe conditions like trisomy 18, three copies of not chromosome 21 but chromosome 18. These children have much more profound intellectual disability, a life expectancy of around 10, and they often need a heart transplant. So if you really take seriously the principle of equality, they should have an equal chance. But we don't take equality, or many people don't take it to that degree. So just to show you a, sorry, I'm trying to get out of this now. How do I get out of this presentation now? Which one? Oh, escape. There you go. All right, sorry, I'm trying to use just that thing. Okay, let me show you another set of all of this work is some work I'm doing with Dominic Wilkinson, and we had a BMed Sci student, Chavi, who we supervised to do this thesis. We did a survey of around 150 ordinary people called the Mechanical Turk survey, and we gave them various dilemmas. So in this one, question 10, there's a baby needing a bed, there's only one bed, there's a 49% chance of one baby surviving and a 51% chance of the other baby surviving. Would you give preference to the one with the better prognosis, or would you toss a coin? The utilitarian response is choosing the option which brings about the greater expected good. The egalitarian option is to give equal chances. So when there's a very close difference in terms of outcome, so 49 versus 51%, roughly half people are egalitarian, as you were in the Down syndrome case. But as the differences increase between chance of prognosis, people become more utilitarian, the blue bar. They say you should give preference to the child with the higher chance of survival in this case. And when it comes to disability, should you give the treatment or the intensive care bed to a child that's not expected to have any disability versus one with a mild disability? 68% said you should give it to the child who's going to have no disability. 22% said you should toss a coin. And as the differences in outcome in terms of disability increase, again, people become more utilitarian. Likewise, for life expectancy, if they're very close, the only time we got more egalitarian answers was when the life expectancy was 40 versus 41 years. But for every other difference, people were utilitarian. And again, this is the number case. So people sometimes say you should never put a price on people's lives. But with limitations of resources, money equates to number. And that's a simple kind of fact of life. So if you've got $100,000 and you've got one individual whose treatment is going to cost $100,000, you can treat that one individual. If you've got 10 individuals whose treatment is going to cost $10,000, it's 10 individuals, so it's 10 or 1. So we gave these sorts of dilemmas. And in fact, one person, exactly as here in the 5 and 1 case, said you should toss a coin. But people in general prefer to save the greatest number. Okay, so when it comes to real life practice, people are quite utilitarian. And when it comes to surveys of the general public, at least this one, people say you should take prognosis and length and quality of life and cost into account. The first point to note is if you're really an egalitarian, you shouldn't take those things into account, at least maybe cost. Number, maybe you should consider, but certainly not length of life or quality of life. Now, how should you take those into account? Okay. People in medical practice have standardly taken them into account by trying to say, well, we should always do what's in the best interests of patients. So when one of those factors, probability of survival, length of life, quality of life, is so low, it's no longer in that individual's interest to continue to treat. So the problem with that is that there's very few cases that I've seen where treatment is not clearly in the interests of the patient, but a lot of cases where doctors limit treatment. So let me now give you some examples of the sort of thing that come up in this sort of debate. Let me go back to the start. Okay. All right, so which of these do you think is futile or not in the interests of the individual who's going to live the life? Resuscitation of a 23-week baby. The very margin of life is 23 weeks, 22 weeks. What about resuscitation of a baby at 22 weeks? Is that not in the individual's interests? What about if the baby has such severe heart failure that you have to put the baby on what's called extracorporeal membrane oxygenator, a machine to put oxygen into the baby's blood, and where the survival is going to be less than 2%? Is that not in the person's interests? Surgery for a very severe abnormality called congenital diaphragmatic hernia, where it has poor prognostic factors on ultrasound. What about intensive care for 2 years? Is that futile? People often say after 100 days, 150 days, it's futile to continue to treat this baby. How would you answer that question about whether it's futile or not? It's not in the interests of the baby. What about heart transplant for, say, trisomy 18, or long-term parenteral nutrition, or long-term mechanical ventilation? All of these are conditions where one doctor will say it's futile, another one will say it's not futile, and they'll all cite length or quality of life. Okay? But there's no science to what they're saying. It's really just depends largely on their intuitions. And if you look at the standard definitions within, we were just talking about this, there's a major futility project here at QUT. Standard definitions that are used by institutions like the National Health and Medical Research Council or the Australian Medical Association. They define futility as no chance of benefit for the patient. Well, let me ask you, if you had a massive stroke and the only treatment available had a 1 in 100,000 chance of curing you, would you call that futile? 1 in 100,000 chance. Of course, it's not futile if the option is death and there are no side effects or downsides to the treatment for you. But futility is often defined in terms of a less than 1% chance of having a beneficial effect. So, for all of these reasons, I think that this second criterion of appealing to a length and quality of life and probability of beneficial outcome, very difficult to implement in absolute terms, to say some intervention is not in an individual's interests. If the individual says, I don't want to have that, I don't find my life, that's one thing. But that's really the first criterion. However, it's much easier, as you all just did in that little survey, and as people in the general public do, to say, should we give preference to 5 or 1? And if you say that, then you say you should give preference to people whose life-saving treatment is 1/5 as expensive as people whose treatment is 5 times as expensive. Or it's better to give preference to somebody who will have a longer survival rather than shorter survival. Those are distributive justice questions. They're not saying that it's not in your interests to have treatment if you've got a poor prognosis. It's saying that we should prefer better prognosis patients to poorer prognosis patients. Now that's very controversial. Some people, and I mentioned this philosopher Turk, but bioethicists like John Harris, say you shouldn't consider prognosis at all, that this is discrimination and inegalitarian. So there is a debate about whether prognosis should be included or not. But as I mentioned already, in practice and in the public, prognosis does have traction, and I believe it should have traction. Now, if you think that we should take prognosis into account, how could we do this more systematically? How am I going for time? I don't. Yeah. So, Dominic and I have tried to think about how you could draw lines in a way that's defensible, transparent, and consistent. And now I want to talk about how we could ration rationally, if you want. I hadn't thought of that term before, but I might call my talk rationing rationally in the future. So here's how we should ration rationally. So people come up with this list and they say, look, it's mandatory to not provide treatment with no chance of benefit. Well, in all of those cases I mentioned at the start, resuscitation at 22 weeks, ECMO for less than 2% survival, that's not no chance of benefit. There is some chance of benefit. It's just very low. We should not provide life-sustaining that will leave a child with a life that's worse than nothing. Well, I defy you to give me a systematic definition of what a life that's worth nothing is. I'll give you two cases that seem pretty close to it. Epidermolysis bullosa, where from the moment of birth, all the skin continually peels off and you have horrible, painful blisters that get infected and you die within a few months. It's pretty, and you know, there is no treatment for that. That's probably a life that's not worth living. But apart from that, is a life with an IQ of 40 not worth living? Or is a life with complete inability to move anything other than your eyelids, is that not worth living? Well, if you ask people in that, they say it is worth living. Very difficult to have. And if you look at all the legal cases, there are no actual principles. There's a lot of woolly language like unbearable to the individual. And having looked at this for 15 years, I believe there are lives that aren't worth living, but I don't think that I can give you a very good definition of it. And we should not provide treatment that will do more harm than good. Well, in all of those cases I gave you before, can you tell me if it's going to do more harm than good? It's very, very difficult. Yet these are the sorts of criteria that doctors use all the time. And I'm sure there's doctors here that are going to disagree with me. I think you're much better off by saying this life is better than that life. And that sounds discriminatory. But you know, if we were faced with a choice, would you rather live another 15 years or 20 years? It's I'd rather live 20 years. And so if you don't know which individual you're going to be, this is another kind of tradition of thought called the contractarian thought. You would choose that the treatment, if it can only go to one individual, would go to the one who is going to have a better prognosis. Now here's an example of how difficult it is to make these decisions. This is a baby born in Canada who had a progressive neurological disorder called Lee's disease. Baby was going to die within a few months. The doctors there refused to perform a tracheotomy to continue artificial ventilation for those period of months because they said it would be futile, that his disease was terminal, and he should die at home. However, after several months and efforts by American pro-life groups, he was transferred to a Catholic hospital in Missouri where the treatment was performed, and he lived for several months. So that family didn't say that that treatment was futile. It's not clear to me that that existence was futile. However, it is clear that it's expensive for very little benefit. So if you had one bed available and you have a child who's come in with a severe anaphylactic reaction who's going to completely recover, and baby Joseph, you have to decide who you're going to ventilate, I think, and some people find this controversial, I think you should ventilate the child with the anaphylactic reaction. I think that's a defensible judgment, but that's a resource allocation judgment. It's not a judgment about futility. It's not saying baby Joseph should die, as the doctor said these children, individuals with Down syndrome should die. It's saying that we don't have enough resources to save everyone, and we have to make judgments about value of life. So rationing, in my view, requires judgments about value of life. I think the challenge is to make those in a way that can be articulated and defended. And this is a French economist called Dupuy, who invented cost-benefit analysis. And I'm just going to run through how you could use this to try to look at these sorts of dilemmas. Oh, sorry, that's Dupuy. Now, every country sets limits on how much they'll spend, and they don't tell you this, but they do. And this is a study of the limits that are put on how much you will spend to buy one healthy year of life. So every day our lives are put a dollar value, the government puts a dollar value, when they're deciding whether to put a new set of safety on a road to save lives, or in this case, how much to spend on a particular treatment. There's a cost effectiveness analysis, and in the UK, they will spend $20,000 per quality adjusted life year. In Australia, it's about the same, about $40,000. So that's the range that you have. What you can do is you can use this figure. If you've got that figure right, If you were able to arrive at a principled way of deriving that figure, so you got your whole health budget, and you worked out, right, you know, we've got X billion. How many quality adjusted life years can we buy with that? Right, that's the cost per quality. We're going to look at each treatment relative to that. You could make principled decisions. In fact, part of the reason that £20,000 per quality is chosen, a quality is a quality adjusted life year. It's a life year of life that you live adjusted for its quality. So 1 is a full healthy year of life, 0.4 is severe disability. So if you save someone's life with severe disability, you save 0.4 of a quality. Now, if you could arrive at that figure, you know, rationally, I think you could do the sort of thing I'm about to do. In fact, 20,000 comes from the cost of renal dialysis, which is thought to be a reasonably expensive therapy. So there hasn't been a lot of thought to what this threshold cost per quality is. But let's assume that you can get this figure. You can then derive resource-based thresholds for various probabilities of survival, for length of survival, for quality of survival, based on that basic figure. Okay, so if you accept, and I'm going to use UK pound figures here, £20,000 is as much as we should spend per quality adjusted life year. You can then ask yourself, how long can a neonate spend in intensive care for intensive care still to be cost effective? You can ask whether ECMO is cost effective or not. Okay, so I'm just going to quickly run through these because the mathematics isn't important to you. The mathematics is based on various studies that give figures for duration of survival, quality of survival, and so on. I just want to show you in principle how you could think about answers to the sorts of questions that we were starting with, about whether they are or are not futile in terms of cost effectiveness. Okay, so what about a moderate duration of stay in neonatal intensive care? A moderate duration of stay will cost less than 20,000 qualities per quality adjusted life year. So to use some real figures, the cost for a survivor from neonatal intensive care, is £87,000, where the survival, where if you put that cost in, at a survival less than 6%, you'll cross the threshold of £20,000 per quality. So you only need to get a survival greater than 6% for it to be reasonable to provide neonatal intensive care. So what are the survivals? Well, for 23 weeks, it's about a 40% survival. And at 22 weeks, it's down to 20%, which is getting closer to the 6% that you would need to cross the threshold. Now, it's true this estimate excludes the cost of long-term care, reduction in quality of life and so on, which you can factor in. But just in terms of survival from published data, the survival data suggests that even something as controversial as resuscitation at 22 weeks may well be cost effective, it may well be justifiable. What about this extracorporeal membrane oxygenation? It costs £30,000 to give somebody this, and I used to work in casualty intensive care. There's always a big dilemma if you're going to wheel out ECMO. And people, you know, just had an intuition about whether we should do it in a particular case or not. Now, how does this approach help us? Well, using again the mathematics, you'd need a survival of greater than 2% or higher for it to be cost effective. And in fact, the survival from large trials shows that survival is about 67%. So it's highly cost effective. So you don't have to debate whether ECMO is a reasonable thing to provide. Sorry, there it is again. In adults, that's wrong. Okay, so let's pass it. So how is this helpful? So even very low probability treatments can be cost effective when formally studied. So provided you've got a 2% chance of survival in some cases, it's still cost effective to perform treatment. How much neonatal intensive care would have to be administered for it to cross the threshold? How long would you have to provide intensive care for it to no longer be cost effective? So again, there was a debate at Monash Medical Centre when I was there last time. An infant had been in for 300 days and people were saying, we've got to turn off treatment now, it's futile, it's too long. Okay. Now, there may be reasons to terminate treatment, but in terms of futility, in terms of low cost effectiveness, is that claim correct? Well, let's assume that you've got full recovery. Around 50% of newborn infants on long-term ventilation survive, according to data. And again, the same is roughly true of paediatric intensive care and roughly true of adults after 4 days. So at that level of survival, at a 50% survival rate, it would still be cost effective to treat neonates for 700 days, given their prognosis. So much longer than people, and adults for 100 days. That would mean that they're using up the same share of resource, as somebody with renal dialysis at £20,000 per quality adjusted life year, which is quite striking. Okay, I'm going to finish now. I'm not going to go through all the others. What you can do using this approach is vary the probability of survival in each of these different intensive care settings to work out how long you could justifiably treat for various levels of survival. So we discussed 0.5, but if the actual survival of an individual is 0.75, you could treat for over expected survival, probability of survival, expected survival, you could expect a treatment of 1,000 days. So this at least gives you some principled way of evaluating prognosis, comparing probability, quality of life, and duration of survival and cost, all together in a consistent way. So ECMO, again, you can calculate how long it would be reasonable to treat on ECMO at various cost estimates, and it'd be worthwhile to treat for 12 days at a 10% survival chance. So for intensive care, you could derive various limits to treatment based on best evidence and based on some comparator threshold of cost per quality. And again, you can create charts that vary the probability of survival and the cost of providing ECMO to derive how long they should be provided for. Heart transplantation, again, 3-stage cardiac repair turns out to be cost effective. Heart transplantation, at least for groups with poor quality of life afterwards, turns out to be not cost effective. So providing heart transplantation for trisomy 18 is not cost effective on this analysis. We didn't do it for Down syndrome, but certainly using the 0.4 figure of quality of life after trisomy 18, not cost effective. Okay, you've got the idea. Another area where this would challenge current practice is highly expensive long-term treatments. So 2 examples of that are total parenteral nutrition. So some babies are born, have an ischemic event and infarct or kill off their whole small bowel, so they can't absorb food and fluids. So they have to be on artificial nutrition. Now, whether this falls within the threshold of cost effectiveness depends on their chance of recovery. Depends on whether they can be successfully transplanted or whether they can ever come off that. But in many cases, it turns out to be not cost effective on this account. So here's the probability of remaining on TPN with the cost effectiveness. So it costs £80,000 per year, and if you're going to remain on it, that's going to be the cost per quality. So it's heavily dependent on your chances of getting. I'll finish with this one. Long-term mechanical ventilation. This is something that turns out to be highly cost ineffective for people who have very poor quality of life. So we compare in a paper that we've done spinal muscular atrophy, where you have complete paralysis of all the muscles, including the breathing muscles. These patients are ventilated at home, extremely expensive and very poor quality of life. That turns out to be highly cost ineffective. Whereas there are hypoventilation syndromes where people have a normal life but simply don't breathe at night. These turn out to be quite cost effective on this metric. So I won't go through all the figures here again. Let me finish with this point. So many people have criticised this approach for discriminating against people with disability. So if you have an existing disability, saving your life counts less than saving a life without disability. I personally think that's defensible, because if you think about it from what we call the veil of ignorance, if you didn't know whether you would be an individual with a disability or an individual without one, would you prefer the preference be given to the individual without? I would. But let's assume that you don't share that intuition. You can simply remove quality of life from these calculations. So you can make them simply based on probability of survival and length of survival and cost, okay? And still generate consistent cost effectiveness figures. So you can accept the critique of people from disability studies and still think there is a defensible way of dealing with futility judgments and rationing judgments in a consistent and transparent way. However, you need to go back to the Down syndrome case that I gave you at the beginning. If you think that disability shouldn't be taken into account, then it means our current practices need to be radically revised. We need to give children with Down syndrome, an equal chance of receiving an organ. Moreover, the same applies to dementia. Patients with severe dementia should have equal opportunity to renal dialysis and other expensive treatments, provided that they would derive benefit for as long as somebody without profound dementia. Now, this is a debate the community needs to have. But at very least, I think we need to come down on having some judgment about how we balance these different factors, apart from just leaving it up to the intuition of individual doctors. Because some doctors will be pro treatment at all costs, some will be in favour of treatment limitation for the sake of society or resources or their own judgments about somebody's quality of life. So the nub of this story is that I think it's very difficult to make judgments about what's in someone's best interests if you can't ask them what they want. And judgments of futility are best viewed as judgments about how to allocate limited resources. And healthcare resources are always limited, not just intensive care beds or hearts, but doctors' time, antibiotics, nurses' time, money for treatments. Everything is limited. And in my view, rationing judgments are inescapable. We'd be much better off by making these open and transparent, at least having some principled way of saying, well, that treatment is not going to be provided. In my view, if I were working in intensive care or any specialty, I would be deriving these sorts of policies for my unit, because it's only a matter of time before people wise up to the fact that futility is in the eye of the beholder when it's defined in terms of patient benefits or no benefit. And they will challenge these sorts of cases. I'll finish with one cautionary tale. So there was a legal case in the UK in the 90s called Child B, where a young girl, I don't know, 8 or 10, Jamie Bowen, her name was later released to be, had leukemia, was given one bone marrow transplant in Cambridge, failed, and her leukemia relapsed. And her father wanted a second bone marrow transplant because he'd seen that there's a 5% chance of remission with a second transplant. And the health authority said no, the doctors said no, this is not in her interests. 5% chance of remission is not in her best interest. It's going to harm her. The harms are going to outweigh the benefits. These standard things that you saw here. And he said, no, well, I don't agree with that. I think a 5% chance of remission is in her interests. And the case went to court. And initially, the medical staff were running this line, it's not in her best interest. And they very quickly shifted to an argument that it wasn't a reasonable use of limited resources. They ran a distributive justice argument. And initially they failed. And they failed, and the judge said, you can't just ring the bell of, toll the bell of limited resources. You have to have a principled way of thinking about this. So they came back and it went to the House of Lords, and they came back and thought of various justifications for arguing that they couldn't afford this and that there were better uses of the treatment. And they won eventually, and the child actually had the bone marrow transplant by a private anonymous donor paying the money. But they did have to provide a principled justification even on resource allocation grounds. So my mother's got moderate dementia at the moment, mild to moderate. And there's drugs that aren't available on the PBS. I personally don't think they're going to make much difference. But if I did think they were going to make a significant difference, and they're also not that expensive, I'm sure I could mount a challenge that this wasn't in her interests, and put pressure on the cost effectiveness analyses that the government's putting forward. So I think you've only got a limited window of opportunity for business as usual, and the sort of golden days of as at the Brompton, of making decisions about what's in people's interests and getting away with it may be over. And I think it's far better to get to thinking about what you think is a reasonable use of the resources that you have available. Thank you.
Thank you, Julian, for that inspiring talk, and I'm sure it has inspired many questions from the audience. So please, do we have any questions or comments about issues that Julian has raised? Please.
Can I get back to the golden age which you ended on? You didn't talk about informed consent, but in actual fact, the Brompton example, as I understood it, was that they were rationing cardiac surgery on the basis, in a paternalistic way, that what's the use? They're going to go through this operation. It's going to be not very pleasant for them, hard to explain to them, and they're going to then end up, maybe a few months later, I'm putting the case a little bit exaggeratedly in my direction at the moment, with dementia. If they'd given informed consent, is that all they had to do to be morally correct? I mean, you said that there was plenty of resources for the cardiac surgery, but in actual fact, if you go back a few paces, it may have been more rational to have less cardiac surgery and to take that decision, but with informed consent. Can you comment on that?
Well, informed consent requires that all the options that ought to be available to you are discussed with you. Now, if they had discussed with the parents the option of cardiac surgery and said, there is this option of cardiac surgery, has these risks and benefits, it's up to you to choose whether you have it or not, that then would have been informed consent or informed refusal. But my understanding is the option just wasn't raised, and that was the problem, that they presented a limited option set that wasn't justified in terms of the healthcare budget, the resources that were available, and so on. So we're just talking about repairing a VSD, a hole in the heart. I'm not talking about here, very complex, expensive, like 3-stage repairs. Just quite simple things that were well within the health budget, and that you would have, if the individual hadn't had Down syndrome, would have been offered to them. I mean, anyone with a hole in the heart, would have been offered, a closure of a VSD or an ASD. So they weren't presented with the full range of options, and that's actually what happens, all the time. People just aren't told that there are these options. But as happened and this was back, in the 90s, people now are able to find out what the options are, and they realise it's the same with trisomy 18. People with children with trisomy 18 are now saying, well, our kids should be kept alive until teenage years. That it's discrimination not to offer advanced treatment for trisomy 18. So the pressure is coming more and more, as that case of the baby in Canada shows, to keep people alive according to their own particular set of values. And this idea that we can say, so what happens typically is the doctor say, no, it's not in your interests, and they say it is in our interests, and then it goes to court and the judge typically sides with the doctors. But I suspect those days are numbered, and it's much, I think it would be much more solid ground to say, we've only got this amount of resources for intensive care or cardiac surgery, and we have to have a principled way of distributing those, and this is how we've done it. And that's why we're not offering it, rather than we're not offering it because we don't think it's in your interests. But please, you guys are the expert on futility and so and if I'm saying things about the law or anything, this is the premier health law research centre in Australia. So.
You're doing very well. You're an adjunct.
Thank you. My name is Ross Crawford. I'm an orthopaedic surgeon. I have a chair at QUT as well. I want to throw euthanasia into the mix with this as well. Fractured necks of femur is a cause of death for about 1 in 7 women. I did a back of the envelope calculation. If you come from a nursing home, the quality is probably $300,000 to $400,000 per treatment, because we know there's a 90% 1-year mortality. And it's but we have to operate to keep these people alive, because it's too painful to nurse them with a broken hip. So we're spending millions and millions of dollars to keep people alive for less than 12 months because we have no option. It would be very cost effective to be able to allow them to die, but that's euthanasia. I don't know whether that...
Well, it's not euthanasia if you don't operate. I mean, again, so you're completely right. You could say at the end of this that it's not, that this falls outside the threshold of treatment that ought to be provided with limited. An easier one to sort of discuss is artificial feeding, peg feeding, for advanced dementia. If you wait long enough, people with advanced dementia will require peg feeding. Now, you could keep them alive for maybe another year, 2 years in a virtually comatose state, or you could let them die, allow them to die. So limiting medical treatment is passive euthanasia, yes, you're right, but it's not active euthanasia, it's not illegal, and it would be well within the realm of existing guidelines and practices to say, no, this is too expensive to treat. But I can see that it's going to be very unacceptable to say we should let people with fractured femurs, have palliative care. But the reality is that's I think that's...
Well, palliative care doesn't work because you can't nurse them with broken hips because they get pressure sores and they're in agony. You've either got to let them die quickly. It might take 3 months.
But by palliative care, I mean high dose of sedation and analgesia. I mean, look, if it were me, but let me just say. So here's an advanced directive, right? And there's a sense completely. If I ever get dementia and I can't recognise myself and I fracture my hip, give me the highest dose of morphine. We've written a paper on it saying and don't feed me, or give me fluids and allow me to die. That seems to me entirely a totally acceptable advanced directive. Now, can the community say also, actually because of resource constraints, that's what we're going to do? That's a more controversial position, but one that I think is going to be unavoidable, because you're not going to be able to keep people alive with advanced dementia as long as you possibly can. You just don't have the resources. And we're already starting to sort of poke that beast. So you're going to have to, people hope that advanced directives are going to solve the problem. They're not. So you're going to face this. At what levels of quality of life can we afford to keep people alive? How long can we afford to keep them alive for? Is a year enough, or is a month enough? So those are all questions that you have to face as a community. Whereas at the moment the approach is, well, you know, we just can't do anything to shorten anyone's life, and it's all euthanasia. That's not euthanasia. Euthanasia would be giving them a lethal injection, you know, now because they've broken their hip. Now again, you know, that might be something that you say. I mean, I've had 2 cases of exactly this, you know, in the last year, where somebody has an elderly relative, 90, and they've got hip disease, and they can't find an orthopaedic surgeon to operate on them. In one case, it was because of cardiac disease. And they say, I'd rather die than go around with this hip disease. I don't care if I die. So, you know, give me the operation. And so that's a similar sort of case where they just prefer to be dead if they have to continue on like this. And your case is one, you know, that's related to that, although it's happened through an accident.
The question of self-fulfilling prophecy comes into this quite a lot.
Yeah, I submitted that slide, sorry.
yeah, well, Dominic spoke about that recently. But in neonatology, I think we'd felt that trisomy 13/18, the quality of life was such that it wasn't justified in an active approach. And if you read Smith's recognisable patterns of human malformation, it supported that approach because they usually died within 28 days and they all died by 1 year. But of course, parents are now challenging that, and if you look at the internet now, you see many cases of trisomy 13/18 living even to their teens and young adults, and you know, we thought they could never learn to suck or swallow, but indeed, when you challenge that, it does happen. I think it's a very difficult dilemma. You know, the paternalism of the way we used to practice and what was supported in the literature is being challenged every turn.
But yeah, that may be that we should be putting a lot of resources into trisomy 13 and 18, you know, to see actually what the maximum potential there is. But that's a question we have to answer.
But of course, you know, the way you've presented it as though, you know, the profession have got a very dominant say in what happens. But of course, the parents are acting in the best interest. They have the autonomy at the end of the day, and it's very hard to give non-directive counselling.
Well, again, see, we had this discussion at lunchtime. The claim the parents are acting in the best interests or the doctors are acting in the best interests, you first got to decide what is in someone's best interests. And there are 2 dominant theories of interest. One's subjective, that says your interests are, so what's good for you is what you believe is to be good for you, or what you judge to be good, or what you desire. So purely, that's what economics is based on, and that's what psychology is based on. On that view, it's how much, is your life worth living, is just answered by do you desire to continue to live. First point, it's very difficult to do that in people who aren't competent, or who have never been competent, to make a decision about what, and all this substituted judgment, and it's really a fudge. It's very difficult to apply that subjective standard in people who have never had a subjective perspective. So it's like saying, you know, is my dog's life subjectively worth living? You know, I can't ask him. The other one is objective, to say, okay, certain things human beings typically do. They have personal relationships, social relationships. They, you know, are able to think, affect the world, talk, you know, engage, do various things. The more and more you impoverish that, the worse and worse your life is objectively. Okay, that's another area. But neither doctors nor patients, you know, have a kind of privileged access into what that is. And until you agree what that sort of objective standard is, doctors can go wrong and families can go wrong. And so I think this idea that somebody, even the patient, has a kind of, like, gets their own interests right is very problematic. So I think we kind of say that the whole basis of medical ethics is you should do what is in the best interest of the patient. And that worked fine when, you know, the only thing you had was penicillin and they're going to die of an infection. Yeah, okay, that's in his interests. Doesn't work so fine when someone says, I want my healthy limb amputated because it doesn't feel a part of me, and you know, otherwise I'm going to put it on a track and run it off myself. Is that in his best interest, or isn't it? So we've reached the limit of that sort of concept. Until we make progress on that, it's not clear that it's going to do the work, and just appealing to the family is not going to. Very often the family get the interest wrong. And so what we have is the courts, who are meant to make this decision about interest in the final stage. But having looked at their judgments, I'm convinced that they've got it right. So I think it's this is a sort of, it's the bedrock, but it's also quite spongy when you push it. If you thought the subjective standard, if you accepted that, you'd be committed to this bizarre view that people with Jehovah's Witnesses, it's in their best interest to die for want of a blood transfusion, because that's what they say is in their interests. Now, I think that's a sort of paradigmatic example of somebody being confused about what's in their interests. But now we've got to go to something more objective. And, I can give you arguments about that, and I think I've got quite a good view on it because I've studied for 15 years. But I don't think that it's a very useful thing in medical practice at the moment.
Thanks, Julian.
I'm sorry. Hi, Joseph Ting. I used to work in retrieval services where we'd manage the whole...
In where, sorry?
Retrieval services, where we would manage the whole statewide critical care platform for about 12 hours overnight, and it'd run through me, basically. So I commend you. I think all of what you talked about is important. I just wish I had that education before I had a set of critical care units around the state to kind of send people to from whatever, especially in winter time when there's a big peak of care. So I'm also a retrieval and pre-hospital physician, or was one. So my question to you is this. I've had to, as you know, in winter time there's a heat of competition for adult and paediatric critical care beds, and we do make value judgments, and there are opportunity costs. So for example, if I get called at 2 o'clock in the morning on a Friday, and that bed's taken by a 40-year-old alcoholic person with liver disease who needs to be ventilated, and at 4 o'clock there's a trauma patient who gets run over by some crazy drunk person who think they were a kangaroo on the roadside, then we've lost that opportunity. So oftentimes I've been in a situation where I've had to reverse the decision and make a value judgment about who gets that last bed in Townsville, for example, or in Cairns or whatever. So my comment to you is this: is it morally and ethically permissible to have an iterative process where you're basically using cost allocation arguments, but then you have to somehow in the heat of the moment use other frameworks to not lose an opportunity of something that you think somebody who deserves a better access to critical care beds? In other words, are we allowed to use multiple models when there's a high opportunity cost in a very limited environment where care is very, very expensive, and frankly, you make value judgments? Should we do that? Because I think we all do that, but in the back of my mind, I think sometimes there's not much difference between a 20-year-old with trauma and a 40-year-old who's got alcoholic liver disease, might give up drinking, for example. So are we allowed to do that? And how would you factor in competition for opportunity costs into your equation for how you work things out in high
Look, this was just a sort of sketch of a sort of an idea. So, you should always make, every ethical decision is not relative to people's desires or culture, but it's relative to the situation. So, you may have, an alcoholic who has blown 2 livers and, comes in hepatic failure after continued drinking, versus you may have someone who's been abstinent for a year who needs, a liver transplant and comes in a coma. So they're quite different cases. So having a principle no, intensive care beds for end-stage alcoholic liver cirrhosis is not going to do justice to that. So you always have to consider these as, there is no such thing. There's no such thing as an absolute rule for anything, except maybe child abuse or something like that. But, in any of these situations, there's always going to be competing reasons that you need to weigh. And what it is to be a professional is to have an algorithm or a decision procedure or a set of rules, but then also to look at the whole situation and make a judgment about that particular, and articulate your reasons, which may deviate from what the decision procedure says in this case. But in your case about the sort of flying in, so this is a classic case where with a stroke of a pen we could resolve that dilemma, and that is, you talked about the opportunity costs of putting one person in intensive care. It would be obliterated if you moved them out again, right? So say you put the poor prognosis patient and suddenly a really good prognosis patient comes in, or someone that you think would have got priority had they come earlier or at the same time. Then you remove that person and put the second, but that never happens. People are never, and that I think is a fundamental example of status quo bias. Okay, so because the opportunity cost of having a rule that says take the first come, first served is exactly that you'll put in this terrible prognosis patient and a very good prognosis patient comes in, then you've got to transfer them or they die or something happens. That's got a huge opportunity cost too. So the kind of rational approach is to be prepared to move in some way according to the resource that you've got and the patients that you've got. Now, I think that's a way, so withdrawal of patients from intensive care, I think is again a mistaken attraction to you must do everything you can for the best interest of this particular patient. So the mindset of doctors in that case is, well, this is my patient, I have to do everything that I can. It's not that they're all my patients and I have to somehow consider this guy who's down in casualty because I haven't yet accepted him to intensive care. So that's someone else's problem at this point. So if you consider them in entirety, if it were your own kids, and you had one that was pretty imminently going to die and another one that was going to survive but really needed you'd move them. Yeah. But that's not how we think. And that's an example of, I think, bad ethical thinking.
It's a perfect recipe to end up including now, I think.
It's what?
I remember Barnaby Joyce ringing me out something about that.
All right.
I didn't make it explain my decisions.
Yeah.
But thank you, it's a very good thought.
Yeah, I think it's a very difficult one because you're then stuck with, and I'll give you another one. The first paper I ever wrote, right, this is when I was still doing some medical locums in intensive care, was, a lot of times you get people who come in and you don't know what their prognosis is. And if you start treating them, they get, disabled, more and more disabled, and you don't know whether their life is going to be worth living at the end. But when they get out of intensive care and they no longer need inotropes and ventilation, there's no euthanasia. So you're stuck in that situation. You don't have any, you're committing them. And sometimes also, because of that concern of committing people to a life not worth living, it's not provided. People are allowed to die. What's the rational solution? Treat people until the prognosis is clear, or until they can express their desires, and then give them euthanasia if they're not happy with the result. Because then, you've got the alternative of getting out of that treatment course. And that means more people would be treated, but also more active ending of life would occur. So euthanasia would help you to give more people a chance of a life under subjective uncertainty about the quality of life and their prognosis. And so it's actually a benefit to us, but we're constrained because we don't want to accept that possibility.
Folks, we've probably got time for one question. One down the back there.
G'day, I work in the Department of Health. I'm interested at the higher level if you've seen governments or departments of health apply that sort of philosophy in terms of how they distribute the health budget and to what capacity they fund or don't fund different services, and what effect what that might have and whether there'd be a shift towards primary care if it were applied.
Well, I mean, again, this is just, off the top of my... So the UK does this. They have the National Institutes for Clinical Excellence, evaluates every new therapy, and it measures it against the threshold of 20,000 per quality adjusted life year. And sometimes they fund things that are more expensive for various reasons. So they can deviate from that threshold. So basically, the NHS, in terms of introducing, a new chemotherapeutic agent or a new intervention, it has to pass this, or it has to be evaluated against this test. But it doesn't apply to all of the things that I've just said there, because they're actually just, if you like, standard medical practice that's up to the doctor's discretion. So, it's partially implemented, and I'm sure the PBS will do similar cost effectiveness analyses for drugs in deciding whether to make something available. But it's not, I don't know how much it's done in orthopaedics or I presume it's done in terms of devices and so on. but there's large areas where it's not done. And I personally think that I was just saying before, I would give doctors their own health budget and say, right, you know, orthopaedic surgeons, here's your amount of money, you decide how you're going to spend that, and we're going to measure what you do and, you know, evaluate it. Because I think it's very difficult to do that because there are so many different resources that need to be managed. You can't have somebody at a large distance making those sorts of judgments. But should more go into primary care? I think primary care should be abolished. This isn't going to... So I think the days of primary care, if you look at the NHS, in my view, primary care is there to stop you getting access to first world medicine. It's there as a barrier, and giving GPs the sort of power to control the health budget has meant that it's, you know, and the UK has one of the poorest cancer survival rates in the whole of Europe. Now that's not just, it's also because they've got district general hospitals instead of specialist cancer centres only. You know, there's lots of different reasons. But, you know, medicine is so complicated now that, you know, you need to be on a track, I think, to being managed, you know, by someone with a special. So I would have, you know, much more basic triage, and then, you know, much more investment in the sort of special. Now that's controversial. I mean, some people are probably GPs here and you're completely up in arms. But I think this whole mantra that, you know, the solution that the NHS, you know, having more primary care. Another thing with primary care is a lot of it is prevention, right? So the most cost-effective thing you can do is get someone to give up smoking, okay? Now, is that really how you want your healthcare dollar to be spent? It's, in my view, if you internalise the cost of smoking through paying taxes, so you've paid a lot of tax and you're actually paying for your healthcare, it's up to you whether you smoke. You know, and I don't want, I want treatment to be going to things like, you know, treating heart attacks or things that aren't, you know, so directly the result of your choice. So it seems to me that kind of prevention is quite a different sort of treatment. Now, people in public health to completely the opposite direction. They say, no, actually, that's what we should be doing. Likewise, reducing everyone's risk by 1 in 1,000, right, makes virtually zero difference to you as an individual. Massive public health benefit. And that's how this sort of emphasis on primary care has gone. Now, it's an open question whether it's better to reduce 1 million people's risk by 1,000 or reduce 100 people's risk by, you know, 90%. You know, that's an ethical decision that it requires that you evaluate those different. So again, this is a case where cost effectiveness comes out with, I think, perverse answers. So you'll need other principles. You need ethics. You need more ethics, and health law research centres.
Thanks, folks. It's time to bring this session to a close. One thing that I'm sure that we're all agreed upon is this issue of rationing in the area of health resources is a conversation that we have to have and we haven't had enough of. So it's tremendous that Julian's come along this evening to give us one model, something to think about, but we need to have a lot more conversations. So could you please join with me in thanking Julian.